Hi guys, so I thought I would show some basic anatomy here, just so that you have an understanding on the ankle. So first of all, the ankle itself. Maybe we'll start on the most common, the ATFL. So the ATFL is sprained and it's an ankle sprain, and you can have a low and you can have a high ankle sprain. So the anterior talofibular ligament attaches to your talus. So if you were to draw your hand down the shin bone, and then naturally there's this concave structure, as you continue down, the next structure that you're going to hit is your talus. So if we then continue around the back of your tibia and down, we're still on the outside, the lateral aspect of your talus. So now we want to think, where does the ligament attach? Your anterior talofibular ligament attaches from the anterior portion of your talus, and then it attaches onto your fibula here. And then what that will do is that prevents the excessive inward movement of your foot, to a degree inversion on its own, but mostly plantar flexion with inversion, as you can see here. We also have your calcaneofibular ligament. So that's the calcaneus onto the fibula here. So we can see that if we dorsiflex this position, then we are potentially lengthening the calcaneofibular ligament. If we also look at different structure around here, so if we go lower down, we have the cuboid. So to get to the cuboid, the way I think about it is you would travel down the fibula head, find the bony prominence, then as you take your finger off of the bony prominence, it lays diagonal, so you know you're on the talus first, and then from there what we then will do is drop down and we're straight onto the calcaneus, so the end of the calcaneus, and then we're onto the cuboid. So the cuboid is next to the base of the fifth. Sometimes you'll hear cuboid stress. Normally somebody's going to have cuboid stress if they have a slightly high arch and dorsiflexion. When they run, they may contact the bottom of the cuboid, and then that will then refer into the calcaneus and may cause discomfort. If we move over, we also have the cuneiform, which are almost like little triangles of bone, and then they attach to the base of the first, the base of the second, the base of the third, and then your cuboid attaches to the base of the fourth, and then it floats after there where you have the base of the fifth. So if you were to run your hand around the outside, sometimes you can get an avulsion where the tendon is ruptured on the outside of your foot here. If we go to the inside now, we have your tibio-calcaneal ligament. We also have your tibio-navicular ligament as well. So TN and TC is the way I think about this. And as we've already spoken about, on the opposite side, when you have a high arch and we supinate in this position, you have cuboid stress, but when you have a low arch, then you have navicular stress, which is when we pronate the foot and the foot comes down, it drops down. So when the foot drops down, what we then have is stress on the bottom of the navicular. So if we were to identify a navicular, similar principle to here, So if I go from the bottom of the fibula, one fingertip on average, we're onto the talus. If I did the same on the tibia, and then if I was to pull one fingertip along the side, we're onto the navicular, and then we're on to, after that, sorry, that's slightly incorrect. I was wondering, I was confused there. We're onto the talus, then we're onto the navicular, then we're onto the cuneiform. I was wondering why my brain was questioning that there. And then, right, so if we move on from that, sometimes somebody will have a stiff ankle on the front of their ankle, and normally that is caused because of the talocrural joint. So if we look down here, this is supposed to open and close. So if I was to do an angle like this, it glides. But sometimes if it's stiff, it doesn't want to glide. It remains fixed in a closed position or fixed in an open position, depending on ligamentous instability, anything like that. Okay, now we've looked at the talocrural, now we're going to look at the subtalus, which is underneath the talus, and we can see the gap between the calcaneus and the talus. If I can show that, is called the subtalar joint. If we go back to the lateral aspect, so the outside of the ankle, this is normally where we have your inversion sprain. When we sprain on the lateral aspect, we will also strain and stress the muscles on the lateral aspect, which is your peroneal complex. Your peroneal complex will come down and wrap around the base of the fifth here, and then it comes round onto the base of the first. So for instance, if you have tension into your peroneals, it's going to pull your foot outwards. When it pulls your foot outwards, it may also pull down onto your cuneiform here, slightly dropping the foot, not too much, but mostly creating this eversion and this what we call supination of the foot. If we go to the lateral aspect, we obviously have the Achilles heel that we all hear about. So the Achilles heel attaches onto the back of the tibia, runs down the back, and then into the heel of the calcaneus here, and then after the Achilles heel or the Achilles tendon, we then have the continuation of that, which becomes the plantar fascia. And plantar fasciitis is the most common term that a lot of runners and people that are very active but maybe are not the best with anatomy and understanding biomechanics will have pain running around the posterior aspect, so the bottom of the foot. Likewise, if you have normally seen with plantar fasciitis, the pain is mostly on the medial aspect here, which will pull and create a higher arch, but it just compresses the structure together, and then it holds it under a tensile force, which is why it becomes inflamed, and that's why you would hear the common term plantar fasciitis. Oh, I have plantar fasciitis. If we come along to the tibialis posterior attaches down onto the navicular, and if this muscle is weak, then it doesn't do the job of holding the arch in the foot. It collapses down onto the navicular, which is this part here, collapses it down, which will pronate the foot, and then mean that you're going to impact, if you're a runner, down this medial aspect of the base of the first, down through your cuneiform, down through your navicular and into your talus. And then on the back we have the gastrocnemius complex. We also have the soleus. So the soleus runs down, attaches onto the Achilles, then that attaches onto the plantar fascia. But if we go from the soleus and continue up, then we have on the back of like a knee, we have the medial and lateral gastrocnemius. So if I wanted to plantar flex, if I want to take my foot and bring it this way, what will happen is my calf will naturally contract. So there's some basic anatomy for anybody that's interested in understanding anatomy a little bit better. Hopefully this video helps.